All right, here we are, back with part 5 of chapter 11 and the last part of this chapter. I know you guys are probably doing a small celebration right now. We're going to pick right up where we left off talking about the secondary assessment. We're going to dive into this and then towards the end of this part, we'll talk just a little bit about the reassessment process. But we'll start where we left off with part 4, but we're going to get into a part that's oftentimes uncomfortable for us medics to not only talk about, but to perform when it comes to the assessment process. And let me reassure you, it's equally as awkward and uncomfortable for our patients as well. And that's why we need to make sure that we approach the assessment of the regions I'm going to talk about next from a very clinical and a very professional standpoint. If you do it any other way other than very clinical and very professional, that's when you can kind of get yourself in trouble. But also realize that when it comes to assessing genitalia, male and female genitalia, most of the time it's not involved in a really dire emergency situation. Sometimes it can be. There can be significant blood loss or a significant amount of trauma, those kinds of things that really requires us to get in there and do some direct pressure and assess for a wound and those kinds of things. But that is not typically the case. However, when those times do arise, it is very important that you behave very professionally and very clinically. So with that, we'll get on with it. Of course, the assessment of the female genitalia should be performed on only a very limited basis, but in also a very discreet fashion, keeping the patient privacy and dignity in mind. So we're going to keep the patient draped so we're not exposing them to the world. If possible, a male paramedic should be assisted by a female paramedic whenever possible, or by another female, even if they're not another medic. The only reason to examine the genitalia are to address life-threatening hemorrhages or an imminent childbirth delivery kind of a situation, as I've previously mentioned. The assessment should include palpating both the bilateral inguinal regions and the hypogastric regions as well, looking for, because the female genitalia, most of their plumbing is internal, most of the problems, or a lot of the problems that they can have, can be lower abdominal types of problems. So it's really important that we assess those areas as well. Clinical reasons for pain on palpation of the fallopian tubes and ovarian regions include things like an ectopic pregnancy, or there could be complications of a third trimester pregnancy, non-pregnant ovarian problems, and pelvic infections. Of those, third trimester pregnancies and ectopic pregnancies are going to be kind of the top of the list of urgencies that we might run into, that we want to consider. There might be something pretty serious going on. Should also note any bleeding, inflammation, discharge, swelling, and lesions that you may find during your assessment. On the male side, things are a little different. All of their plumbing is pretty much external, with the exception of a couple of things, but the majority of it is external, so it's a little easier to assess, or at least narrow down what may be going on. You should examine the male genitalia in a limited fashion, just like we do with females, and having a partner, someone else present. In cases of trauma, assess for bleeding, injury, and underlying fractures. Be sure to note any inflammation, discharge, swelling, or lesions, just like we do with the females. Realize, though, that a priapism or a prolonged erection, which is usually the result of a spinal cord injury, may be present. That can kind of throw you for a bit of a loop. Remember, this is going to be something that is prolonged, and it has nothing to do with any kind of stimulation or anything like that. It is caused by spinal injury. And then look for any evidence of urinary incontinence or anything along those lines that might be noteworthy. The last really personal part we're going to talk about is the anal region. The anus is often evaluated at the same time we evaluate the rest of the genitalia, but it is examined only under a very limited amount of circumstances, much like the other two regions that we've discussed. When you do this exam, keep the patient draped and ensure that your partner's present, like we do with all of these types of exams. Assess for the need for bleeding control or other types of interventions. You should also examine the sacrococcygeal region and the perineal areas for bleeding, trauma, lumps, ulcers, inflammation, rashes, abrasions, and evidence of incontinence. Now, we talked about these three regions, male, female, and the anal region. Realize that we're going to talk about all of these in a later chapter, so we're just looking. We're not diagnosing or finding, deciding what kind of treatments and those kinds of things to do. We're just looking right now. We'll talk about what we might find specifically in later chapters, as we will with all of the assessment findings that we're talking about. Moving on to the musculoskeletal system. The joints are areas where bones meet to form a kind of a hinge. They're filled with shock-absorbing linings and fluids held together by ligaments that allow the body to perform mechanical work. Skeletal muscles are then used to flex and extend the joints and are anchored to the bone by tendons. Joints become much more vulnerable to injury, stress, and trauma as we age. And of course, that crepitus that you've heard spoken about in your EMT class is a normal variation of aging that sounds like a crackling or grinding sound. So, when you get up, I'm sure a few of you are probably already feeling this, but the snaps, crackles, and pops that you hear and feel when you stand up or when you move a joint after you've been sitting for a while is known as crepitus. Now, we can also have that crepitus feeling too when the ends of two broken bones are rubbing together. That can give you that very similar sensation, but it's a different cause, and they're both called crepitus. Common types of musculoskeletal and soft tissue injuries include fractures, sprains, strains, dislocations, contusions, hematomas, and of course, open wounds. A fracture, as you know, is a broken bone, which can either be pathologic fracture or a traumatic fracture, meaning it can be just a weak bone that fractures, or it can be due to traumatic events such as a fall or an automobile accident. So we can run into either types of these fractures, but the pathologic fracture, like I say, is usually the one that we see when we have either abnormal bone structures or a reduced bone density issue, and sometimes those will just happen. Somebody will be walking and their bone will break because of the stresses that are put on the bone and its weakened state. When examining the skeletal joints, pay attention to their structure and how they function. Note any limitation on the patient's range of motion, pain with movement, or the sensation of that bony crepitus that we talked about. Look for evidence of inflammation or injury and evaluate for obvious deformality, diminished strength, atrophy, or that wasting away where the bone or the muscle is just shriveling away because the limb is not being used, or the presence of any asymmetry on one side or the other. One side looks bigger, smaller, or whatever than the other. Two sides don't match. Pain is always considered an abnormal finding. And then, of course, if you really want to look at this a whole lot closer, you can look at skill drill number 10 in chapter 11. That'll give you the correct way to examine the skeletal joints and all of those things that are related to assessing that. Problems with the shoulders and related structures can often be determined by noting the patient's posture. You should palpate the proximal upper extremity of the shoulder, assessing the sternoclavicular joint and the acromioclavicular joints, easy for me to say. the subchromal area and the biceptal groove. I get saying them and I get tongue-tied and I can't say the rest of them that are actually easy to say. So you're going to assess all of those joints and those areas of the shoulder. During this, you're going to look for any tenderness, swelling, of course, crepitus, deformality, limited rotation, or swelling to that particular area and bruising. You look at this shoulder, we look at it, something does not look right with it. We can't make assumptions, but we're going to palpate that shoulder and see what's going on. It could be a normal finding for this person. Maybe they've got a previous injury, or it could be something new and we note tenderness and that kind of stuff there that would give us an indication that maybe we need to immobilize that joint and transport them to the hospital. To assess range of motion, ask them to raise their arms vertically above their head and then have the patient demonstrate external rotation and abduction by placing both hands behind their neck with their elbows to their sides. Finally, have the patient perform an internal rotation by placing both hands behind their lower back. Now remember, all of these that we're going to talk about, these range of motion things that we're talking about, if there's pain, discomfort, swelling, abnormalities, those kinds of things to that joint that are new, we're not going to have them do a range of motion test. So if they have something, a deformality or something that's different, something looks a little off about a joint, and they go, oh, no, that's been like that since I was born, or that happened to me in the accident of 96, then we might go ahead, it's okay to go ahead and do a range of motion. But if there's pain or tenderness, that kind of thing with that joint, even though it's an old injury, we're not going to do range of motion tests on those types of things if there's discomfort. And along the way, if there's discomfort while we're doing the test, if there's pain, we're going to note that, and we're not going to keep pushing them to continue on with that range of motion of that particular joint. Look at the elbows for any obvious big-time deformality or abnormal rotation. Palpate the elbow between the epicondyles and the olecerain processes, and note any tenderness, crepitus, swelling, or thickening. Assess the patient's range of motion by having them passively and actively flex and extend their elbows. You should also have the patient supinate and pronate their forearms with their elbows flexed at their sides. So turning their hands in and out, basically, pronating and supinating. You should inspect the hands, wrists, and for any deformalities, and then palpate the hands. When palpating, check the medial and lateral aspects of each interpharyngeal joint of the finger, and then squeeze the hands, compressing the metacarpopharyngeal joints. Next, palpate the carpal bones of the wrists. To assess range of motion, ask the patient to make fists with both hands and then extend and spread their fingers out. You should also ask them to flex and extend their wrists and move their hands laterally and medially with their palms facing down. Finally, check capillary refill, the symmetry of their radial pulses, and the overall temperature of their limbs. If practical, you should evaluate the patient's ability to walk, inspect the knees, hips for overall alignment and symmetry, and identify any deformality, shortening, and or rotation. Look for evidence of thickening, swelling, or bruising of the thigh, and note any crepitus or palpable tenderness. To check the patient's range of motion, ask them to bend each knee and to raise the bent knee toward their chest. Assess for both passive and active rotation and abduction of the hips. You should also palpate each hip and palpate and gently compress the pelvis downward and inward. But remember, as we've seen on that very first video, your book's going to talk about this. But generally speaking, we don't do a whole lot of pressing around on the pelvis. We might do this in a non-trauma patient, though I'm not really sure why. But generally speaking, we're not gonna do pushing around on their pelvis, and odds are we're not going to do a whole lot of range of motion testing on them either. But there may be some extreme cases or some unique cases, not extreme, but some unique cases where that range of motion, knowing that, is going to be helpful. So then we work our way down to the feet and ankles, looking for any wounds, deformities, discoloration, nodules, or swelling. That's the main thing we're looking for. Palpate all aspects of the feet and ankles and measure the distal pulses over the dorsalis pedis and the tibius posterior arteries, or tibialis. Assess the overall limb temperature and check for capillary refill, especially in pediatric patients. To assess the patient's range of motion, have them plantar flex, dorsal flex, and invert and evert their ankles and feet. So basically you're just going to have them push their feet down, lift their feet all the way up, turn their feet in and out. Finally, inspect and palpate and check the range of motion in the forefoot and toes. The peripheral vascular system includes all aspects of the circulatory system except for the heart and great vessels immediately involved with the mediastinum and the coronary circulation. So we're not going to mess with coronary and pulmonary circulation. We're just talking about all the peripheral vascular system. In this is the lymphatic system, which is a network of nodes and ducts of various sizes dispersed throughout the body. Lymph nodes are larger and they accumulate they're accumulations of lymphatic tissue. Though smaller amounts of lymph are also distributed throughout the tissues in the body. All lymphatic tissue contains large number of immunological active cells, so it's part of our immune system. And it's also sometimes an early indicator for an infection or disease or something going on. Whenever you go to the doctor, it's one of the main areas that they will assess when you have a cold or you're not feeling well. They'll check your lymph nodes and see if they're swollen, because that's an indication that your immune system may be a little overly active, trying to rid itself of something that doesn't belong. Perfusion occurs in the peripheral circulation through a network of capillary beds. Diseases of the peripheral circulation are often seen in patients with other underlying medical conditions such as diabetes, hypertension, dyslipidemia, obesity, and tobacco use can contribute to that as well. During your assessment, you should pay attention to both the upper and lower extremities. Look for any signs that could indicate either acute or chronic vascular issues, such as, a brightened red extremity that maybe is indicative of deep vein thrombosis or something like that could be going on. You can refer to skill drill number 11 that will give you kind of the correct way to perform this assessment, a visual look at how to do that assessment. Inspect the upper extremities from the fingertips to the shoulders, noting their relative size, symmetry, and any abnormalities that you find along the way. If it's indicated, palpate the and axillary lymph nodes. Basically, if they're complaining of an illness or some kind of sickness, they're not feeling well, you can feel those lymph nodes. There's some lymph nodes underneath the armpits and up around the jawline of the neck. You check for symmetry. Also palpate the patient's radial pulses simultaneously. The 5 P's of acute arterial insufficiency are pain, pallor, paresthesia, paresis, and pulselessness. So those are the big things that we want to watch out for, and those are all noteworthy things. Also things that are those pertinent negatives. If you're suspecting that and you're not seeing some of those things, you see a few but not all. Look at the lower extremities from the groin and the buttocks to the feet, comparing the right to the left side. Note any remarkable venous patterns or enlargement and observe the skin for pigmentation, color, temperature, and texture. Patients with sufficient or significant vascular insufficiency may display redness, bruising, or paleness in their extremities. Note the presence of any rashes, scars, or ulcers that you find along the way. Palpate the pulses in the lower extremities at the dorsalis pedis and the posterior tibialis, the femoral region, and as well as the popliteal region behind the knee. Note the temperature of the feet and legs and attempt to palpate if there's any edema by pressing your thumb over the top of the foot at the tibialis and the tibialis with a firm, gentle pressure for at least 5 seconds. Finally, palpate the superficial inguinal lymph nodes to see if there is any enlargement in that particular area. Sometimes enlargement in the inguinal lymph nodes can be an indication of something more serious that may be related to, I'm trying to think of my words, but lymphedema or those kinds of things. Some cancerous cells may be present. That's oftentimes where they'll begin to show up there, is in those particular lymph nodes. The spine, of course, still consists of 33 individual vertebrae. You should inspect the back from both the posterior and lateral aspects, paying attention to the curves in the cervical, thoracic, and lumbar regions. When you find those curves, lordosis is one of them that we might find. That's the inward curve of the lumbar spine, just above the butt cheeks, and it's an exaggerated form of lordosis that results in what's known as swayback. Kyphosis, on the other hand, this is the outward curve of the thoracic spine, and scoliosis is the sideways curvature of the spine, and these are almost always an abnormal finding. A little bit of lordosis is normal, so that a little bit of inward curve in the lumbar spine is not unusual. It's considered normal, but an exaggerated curve is problematic. Here's an example of those. The lordosis on the very first one on your left is not overly bad, but you can tell that it's actually shifted the pelvis back. Kyphosis. In the middle picture, we often see this as people age. And of course, scoliosis is the last one of those 3 images. They're pretty apparent when you come across them. Oftentimes, it's not new to them. They're aware of that physical finding that you're going to see. You should palpate the spine using your thumb to touch each of the spinous processes. This allows you to identify any tenderness, step off, or crepitus that may be present. Any abnormality should prompt you to institute splinting and or some kind of protective measures, especially when there's been trauma involved. However, if we've got this person that is in picture number 2, the center picture there, placing them on a long spine board is going to be torturous for them. That is not going to work. You're going to wind up with airway issues and those kinds of things. And there's not a backboard out there that's going to be made to fit this person with that kyphosis, that severe of a kyphosis. And then check the rest of the back for any other significant findings on palpation. You should tap over the costovertebral angles, palpate the scapula, the paraspinal areas and the base of the neck, and check the areas around the buttocks to see if there's any injuries. It's a pretty significant fracture there. In that, we might not notice that fracture that you see on the image there on the right. We might not notice that fracture just on visual observation, but on palpation, it would be rather obvious when you start feeling that spine. Never passively evaluate the patient's spinal range of motion. If any pain or tingling is elicited, stop the exam immediately and immobilize the spine. So when you notice something is amiss with the spine, we are going to try to do what we can to immobilize and secure that spine so that no further damage can come of it. The nervous system, of course, is divided into 2 main parts, the voluntary and the involuntary, or the autonomic nervous system. The involuntary system is further divided into 2 more parts, the sympathetic and parasympathetic. Not confusing at all, right? I know you guys just, it's been a month or 2 since you finished anatomy and physiology, but these things are all very, very important to kind of keep fresh on your mind so that you can kind of understand what's going on with your patients whenever the nervous system is involved. Of course, a reflex, if you remember, is an involuntary motor response to a specific sensory stimulus. There's those primitive reflexes. They're normal findings in infants, but are considered abnormal findings in adults. The Babinski reflex test may be used to check neurological functions, but you should not perform this test on a patient with lower extremity injuries because it can very well give you inaccurate readings or inaccurate results, or it could cause some further issues. When performing a neurologic exam, you need to determine the patient's mental status using the AVPU scale. Cranial nerve function, distal motor and sensory function, and deep tendon reflexes are all the areas that we're going to need to look at when we're doing that neurological exam. The cost map mnemonic is a tool you can use to perform mental status examination, with each letter standing for an aspect you should assess: consciousness, orientation, activity, speech, thought, memory, affect, mood, and perception. The good news is a good, thorough patient assessment is going to hit all of these spots in one way or another, so that you're going to be able to make a determination if there's anything amiss in any one of these areas. Cranial nerve exam determines the presence and degree of a patient's disability. This exam can actually be performed in less than 3 minutes, so it's not a lengthy thing to do. So when evaluating the motor system, observe the patient's posture and body positioning, watch for involuntary movements, and note their quality rate, rhythm, and amplitude. To evaluate muscle strength, have the patient actively move against your resistance. The strength is graded on a scale of 0 to 5, with 5 being a normal state. To check coordination, you can perform a finger to nose or heel to shin test, as well as an assessment of their stance and gait, and pronator drift test. To test proprioception, which is the patient's understanding, their brain's understanding of their position of an extremity, have the patient close their eyes and move their large toe up and down, asking the patient which direction it is moving. This will give you an indication of whether or not their brain and their body is connecting spatially to know where things are, and how things are moving. So if there's a disconnect, it'll help you determining whether it's spinal injury or possibly a brain injury. You should check a patient's sensory function bilaterally, assessing both sensory functions and cortical sensory functions. A dermatome is a distinct area of the skin supplied by a specific sensory nerve. So we have, it's kind of interesting the way that the body's made when you really think about how each small area of the skin is innervated by a nerve that goes back to the brain, that senses what is going on in a particular area. And this is why when you have an itch on your forearm, your brain says, hey, you have an itch here on your forearm, and you're able to find it and satisfy that itch by scratching it. That's where these dermatomes come in, but they're that sensitive and that specific to a particular area. They can be fooled, they can be damaged, and they can give erroneous results and send weird and strange signals to the brain that can be confusing for the brain to interpret. Delirium, on the other hand, is consistent with an acute change in mental status that is secondary to some underlying factor or incident. So delirium is not a state in and of itself. It's a response to an underlying something else going on. Dementia, on the other hand, is a gradual and pervasive deterioration of cognitive cortical functions. These are commonly encountered abnormalities in the field. Some others include asymmetry in facial and extremity strength, aphasias, ataxias, dystonias, seizures, vertigo, visual changes, tinnitus, and tremors. There's a lot of things that we run into in the field that's related to the nervous system or has a connection to the nervous system, but it may not be directly caused by the nervous system, it can be a response to something, or it can be the result of damage to the nervous system. So there's a lot going on. But any one of those things are very noteworthy if we find them. So what do we do when we got an unresponsive patient? How do we assess an unresponsive patient? So, well, it's pretty simple. After we rule out trauma, place the unresponsive patient in the recovery position. However, if trauma is a factor, we're going to position them in neutral alignment and apply the proper sized C-collar and follow our protocol for spinal immobilization procedures. Perform a thorough assessment of the patient's head, neck, chest, abdomen, pelvis, posterior body, and extremities. And we're going to look for any signs of illness, or if we suspect trauma, any kind of signs of injury. Get at least 2 sets of vital signs. The first is going to give us a baseline, and the second is going to evaluate the patient's status. As time allows, you can begin to map these trends. You're going to look for changes in the vital signs as time progresses. Always assess the posture of an unresponsive patient, and if there's no spontaneous movement, apply a painful stimulus to see if they respond to that. Trauma patients are classified into 2 groups. With those with an isolated injury, which allows you to immediately kind of focus on that specific injury, and those with multi-system trauma. Patients with multi-system trauma, we're going to first have to find ourselves looking for all the problems and then prioritizing everything that we find according to the level of severity. We're going to be constantly thinking about how each injury is going to relate to the other, and how our treatments for those injuries one treatment for one injury may impact what's going on with another injury. When you're performing your assessment, don't become distracted by obvious but not life-threatening injuries. Oftentimes, severe injuries to arms or legs can be very distracting, but they may not be the most serious problem that the patient has. Any trauma patient who is unresponsive or has altered mental status is considered at high risk. So before you examine a trauma patient, be sure their cervical spine is manually immobilized in a neutral position. After you've done this, reassess the patient's mental status and revisit your transport decision process. Any additional physical exam must be done quickly. All secondary assessment findings should be recorded in an orderly and concise manner. Use the specific documentation method required by your local protocols. We've talked about those in previous chapters, and you're going to hear about them again during documentation. But SOAP and CHART and all those types of methods that you can use for documenting your findings is a systematic way that you can make sure that you don't forget something or leave something out, because if you leave it out, it didn't happen, or it's considered that everything was normal if you didn't note anything about it. Be sure to note all objective findings, and as well as those pertinent negatives, and then any other relevant information that you discover along the way that would be noteworthy to put in your documentation. Remember, you cannot discover everything during your secondary assessment. There's going to be things that you miss, but you must keep the total time in the field during your assessment to a minimum. A definitive diagnosis may require evaluation, and oftentimes it does, by a physician, along with lab tests and radiological studies and that kind of stuff, which is just things that we're not going to be capable of doing out in the field. Remember, our assessment is primarily to find those top tier things that need the most attention right away, and then those other things that might kind of try to sneak in on us at the end. That's really what we're trying to do. We're going to use several types of monitoring devices that we have at our disposal. One of them is going to be the EKG. This is one we use a lot. The purpose of using a continuous EKG monitor is to establish a baseline, so we've got a starting point. Any patient who presents with cardiac-related signs and symptoms or other illnesses that may impact the heart should be placed on continuous cardiac monitoring. Of course, the electrodes must be placed on the patient properly, and the leads are usually color-coded and labeled to help with that placement. This is going to be really important that we're placing those leads in the correct place. Later in the EKG course, you're going to learn about doing 12-lead EKGs and those kinds of things. It is even more important that we're placing those in the correct locations. Recent studies have found that more often than not, paramedics are not placing the 12-lead EKGs leads in the right place. So it's really important that during that part of the course that you pay particular attention to make sure that you get those placed properly. However, there are times when the EKG can look completely normal, even when the heart is not working properly. So just because the electrical activity in the heart is working or is doing its thing, doesn't mean the heart's responding in the ways that it should. As I mentioned, a 12-lead is going to look at the heart in a more comprehensive way. There's a lot more leads, hence why it's called 12 leads. But this is going to give us a look at several different angles of the heart to try to localize the site of injury to the heart muscle. Early recognition of this can allow the hospitals to prepare for the patient's arrival, and we can scoot them on into a cath lab a whole lot more quickly by having a 12 lead done in the field. Like I said, though, it only works if we put the leads on in the proper locations, and we do it that way every time. The best way to learn how to use 12-lead equipment is to practice with it and use it. You're going to get a lot of practice with it. To do a 12-lead, the patient needs to be laying flat, and you should make sure they're not moving. So we don't want to do it in a cold or chilly environment where that they're shivering, that might produce some artifact and those kinds of things for the tracing. We want to make sure they're as still as possible. You also need to prepare the patient's skin, or you may run into instances where you do. Connect the limb electrodes, then connect and apply the precordial leads, and then record the EKG. And you can see on the screen here where all of these leads go. Like I said, it's important for you to put them on in the correct location, because being off a little bit on these locations can give you false readings, inaccurate readings. The amplitude looks may be off and they may not look quite right, and so it makes it difficult to do your interpretations. All that will be talked about in the EKG chapter as well. Carbon monoxide or carbon dioxide monitoring. Capnography is the measurement of carbon dioxide output. It also measures carbon dioxide output, but provides a waveform that can be used to assess conditions like bronchospasm, shock, and acidosis. So not only will it give us capnometry will give us a measurement, capnography will give us a waveform. The waveform can be really, really beneficial when we're trying to get a better idea of what's going on with the patient, such as bronchospasms, that we see in asthmatics and those kinds of things, and help distinguish between shock and maybe even metabolic acidosis. For intubated patients, the device is placed on the end of the endotracheal tube, and then it's connected to the monitor, which is typically our heart monitor. For patients that are breathing on their own, there's a special nasal cannula that we can use that collects that carbon dioxide while we're giving oxygen, and it gives us a reading. The limitations, of course, of this device, that it requires minimal airflow to get a reading, and it does require calibration. It can sometimes be affected by secretions and those kinds of things. It's not foolproof, but it is a great tool that we can use in the pre-hospital setting that'll give us a determination of how not only their lungs are working, but how well they're working at a cellular level. The Krebs cycle is working, how they're utilizing their bodies, utilizing the oxygen that they're getting. Blood glucometers, of course, we're always going to check blood glucose in patients that are diabetics. We're also going to check blood glucose in patients that have altered levels of consciousness. And what these do is they measure the glucose in patients who in all of our patients, to get a determination of whether or not that is a factor or an issue. A quick glucose reading can be taken from either the IV catheter hub or through a finger stick. And these modern glucometers provide results in just a few seconds. So used to be we would wait 30 seconds for the results, and different things could, impact those results along the way. The modern ones, it's literally seconds, 2 or 3 seconds before we have a reading. Make sure that you regularly calibrate the glucometer, ensure its accuracy. Some of them come with a calibration strip that you need to use whenever you open a new bottle of glucose strips. But you also need to make sure that the test strips match the glucometer model and they're not past their expiration date. If they're past their expiration date, you may get inaccurate readings for one reason or another. They do expire and they can give inaccurate readings once they are expired. Cardiac biomarkers can help identify damage to the heart muscle. These are relatively new readings that are kind of evolving. These tests are used to find out if a heart attack has occurred. They're typically performed in a lab setting, but today they're managing to make devices that can detect things smaller and smaller. It's probably not going to be long before we're able to look at those biomarkers in the field in a more accurate way. Some rapid tests are now actually available, but these biomarkers can be checked in cardiac patients based on local protocols. They can also be useful in stroke patients who show cardiac-related symptoms. But keep in mind that it may take a few hours after a heart attack for these markers to rise. So that is why oftentimes these patients are admitted to the hospital and they'll monitor these biomarkers over a period of time in either in 4, 6, or 8 hour increments to determine if there's an evolving heart issue. Other blood tests, the iStat is a handheld device that uses disposable cartridges to run an array of common diagnostic tests. A basic comprehensive metabolic panel such as a Chem7 or a Chem12 provide information about electrolyte balances and kidney and liver functions. The BMP test is useful for telling the difference between heart-related and lung-related causes of respiratory distress. So lots of new and innovative testing devices that are out there now. Not all of these are being used a whole lot in the field, but don't be surprised that at some point in time during your career you begin using a new type of device such as the one on your screen to do some blood tests, or doing the panel of tests to determine if there are any biomarkers indicating a heart attack. All right, and finally, reassessment. Here we are back. We're down to the very last part of this on the reassessment flow chart. Here on our flow chart, patient assessment flow chart, we're to the reassessment phase. So stable patients should be reassessed about every 15 minutes. Unstable, we should be reassessing those every 5 minutes. Remember, that reassessment process oftentimes includes a set of vital signs as practical and possible, but we definitely need to be reassessing them and documenting that we're reassessing them. Just reassessing them alone is not enough. We need to make sure that we're documenting our findings of those reassessments as we go along. So stable patients every 15 minutes, unstable every 5 minutes. So if you're taking a transport from hospital A to hospital B and it's a 2-hour transport, you should be doing a reassessment for a stable patient every 15 minutes. If they're not stable, you're going to do it more often, every 5 minutes. So those reassessments are important because they're going to give us an indication if anything's changing, and we can begin to identify trends and have an idea of what to look out for, what may be coming around the next corner. Then we want to check, while we're doing our reassessment, we want to look at the level of consciousness, see if it's changed. Look for any airway changes. Be ready if there's secretions or obstructions that we may need to suction. If the airway is not secure, get the patient ready for intubation. So if things deteriorate to a point that we need to make sure that we have to secure the airway that was once secure on its own, we need to be prepared for that. Recheck breathing status. Watch closely for any signs that the patient is tiring from breathing effort. Reevaluate the circulatory status. Look at the patient's skin color for signs of poor perfusion. Is their skin condition changing? Is it remaining the same? Confirm. Go back and look at those any bleeding issues that you may have discovered, and make sure that they're still fully controlled. Recheck the patient's blood pressure and check pulse rate, rhythm, and quality, paying close attention to see if there's any trends or any changes. Is the heart rate steadily increasing and the blood pressure staying the same? That may be an indication that the patient is starting to drift into compensated shock. Or is the heart rate staying the same but the blood pressure is dropping? Maybe they're transitioning into decompensated shock. Those kinds of things. Those are things we want to look for before they become a problem. Make sure all those immediate life-threatening issues have been managed. Reevaluate your treatment and your transport priorities and see if anything needs to change. Confirm that the original transport decision is still the best option for this patient. Take another full set of vital signs and assess whether your interventions are having the intended effects. What you want them to what you need to happen from your interventions, if that is actually happening. High priority patients should have at least 3 sets of vital signs documented on your run documentation. So we should, we've got that baseline and at least 2 others sets of vital signs documented for these patients. Watch for any development of patterns, such as Cushing's reflex. Be alert for signs of cardiac tamponade, including things like Beck's triad beginning to show up. Review the patient's main complaints and how your treatments have addressed them. And then, of course, record every finding you observe during each of your reassessment turns. Each time you do a reassessment, make sure that you're documenting what those findings are, whether things are getting better or worse. Reassessment is a small part, in the overall scheme of things of what we do, but it's extremely important that we do that, because it's going to give us an indication of how well our patient's doing. Are they doing better? Are they getting worse? Does our transport priority change? Does our destination change? Those kinds of things, because doing a good reassessment and doing them regularly can change where your transport decision lies and your treatments of what you're doing. All right, so that is chapter 11. Feel free to go back to part 1 and listen to the whole thing all over again. I know it was super exciting, right? No, I'm kidding. Chapter 11 is not one of the more exciting, thrilling chapters, but as I've mentioned before, and I hope we've stressed this enough, you're only as good as your patient assessment. You will not be able to find the things that you need to find and be a really good paramedic or even an average paramedic unless you're good at patient assessment. So to be an average paramedic, you're going to have to be good at patient assessment. To be above average paramedic, you're going to have to be really good at patient assessment. It all comes down to patient assessment. You can be the greatest at starting IVs and knowing the medication doses and all of those things. You can be really, really good at those. But if you can't figure out when the most appropriate time to use those are because your patient assessments are lacking, it won't do your patients any good. So being really good at patient assessment is really, really vital. And that's why this chapter is so lengthy. Again, the really long chapters got lots of information in them, and they have lots of information in them for a reason. It's because you need to know them. Don't get caught with your pants down on patient assessments. It'll come back to bite you, and it'll be apparent to everybody very quickly if you're not good at patient assessments. All right, we'll see you.